Good evening, everyone. On behalf of Concord Biotech, it's my extreme pleasure to extend a warm welcome to all our participants. Concord Biotech is a global biotechnology and immunosuppressant leader with strong capabilities in the manufacturing of high quality APIs and finished formulations. With the presence of more than 70 countries, we remain committed to delivering excellence across key therapeutic areas, including rheumatology, immunology, transplantation, and nephrology, driven by a patient centric approach. And it's our privilege today to introduce our esteemed speaker, Dr. Prakash Tiwari, sir. A very warm welcome to you, sir.
Thank you. Thank you so much. Uh, Actually, I'm starting a series especially for the rheumatology residents and students who are preparing for the NEET SS or NEET PG. Rheumatology is not a subject which is very clearly understood while doing even DM also. So I just choose the topic initially pharmacology. As you understand, you have to know the drugs in any field before starting practicing it. Can I start it?
Sure, sir. Just before it starting, just I like to give you, sir, a brief introduction of Dr. Vikas Prakash Tiwari, who is our esteemed
Mm.
guest for today. Uh, Dr. Tiwari, he has completed his MBBS from Pandit Jawaharlal Nehru Medical College with MD in Internal Medicine from Motilal Nehru Medical College, Allahabad, and DM in Clinical Immunology and Rheumatology from SRMC, Chennai. He is an accomplished academician with two international publications and is the recipient of the first prize at CesaraCon Quiz 2024. So, sir, we are really very delighted to have you join us for the first session of the series of academic webinars. And as the topic for the today's session is conventional DMARDs in rheumatology. So, Mr. Tiwari, Dr. Tiwari is going to share his expert insights for this. So, over to you, sir.
Thank you so much. First, let's understand the CS DMARDs. DMARDs means disease modifying anti-rheumatic drugs. We can say previously as a SARD also. SARD means slow acting anti-rheumatic drugs. These drugs are especially designed for the rheumatology and they act slowly. So first, let's understand what is rheumatology and how the disease happens actually. So for to understand any disease, we have to understand first the classification. Next slide, please. Next. So, previous one. So you can see rheumatological disease can be classified into arthritis, connective tissue disorder, vasculitis, miscellaneous. So arthritis can be seropositive or seronegative. Vasculitis can be seropositive or seronegative. Vasculitis can be seropositive or seronegative. What is the means of seropositivity and negativity? Means while doing a diagnosis, antibody positivity not seen in the many cases of arthritis except some. Here also, but connective tissue disorder is a disease in which you will get invariably ANA positivity. So this is a disease, connective tissue disorder, in which we are getting the seropositivity or antibody positivity. So first classification, we can classify rheumatological disease in the four parts, whether it's arthritis or connective tissue disorder or vasculitis or miscellaneous. On the base, this is a rough classification. Next slide, please. So to understand this, we have to understand the immunology. So immunology is very broadly classified into the innate and adaptive immunity. In innate immunity, we are seeing the innate cells like uh, natural killer cells, macrophage, dendritic cells, mast cells, then granulocyte like basophils, neutrophils, eosinophils. In adaptive immunity side, we are seeing the lymphocyte. That can be B or that can be T lymphocyte. So for the classical understanding, we are reading like that innate immunity is separate, adaptive immunity is separate. That can be true for the lower animal. For the higher animal like human, they work together. Some diseases starts from the innate immunity, then they finally goes to the acquired immunity, and some are predominantly acquired. They took the help from the innate immunity. So these two are the connected. Next slide, please. So, what is a pathomechanism of a rheumatological disease? That is so important. So, we have a God theory, God. God theory means generation of diversity. So, we have our acquired cell which has multiple receptors. We have innate cell also which has a receptor. But innate cell has very limited receptors. They are called as pattern recognition receptor. But acquired cell, they are ready to fight anything. So, how these receptors are generating? They are generating through different recombinations. So this is called generation of diversity. So whenever you have a generation of diversity, means you can make any kind of a receptor. Example is like that we are all are human beings, but we all are different by our facial expression or look. So receptors are also different. So by the law of randomness, you can generate a cell which can react your own antigen, your own body. That is called autoreactive T cell. So God has created the tolerance mechanism. That is central tolerance and peripheral tolerance. So they deleted or somehow inactivated or somehow controlled this autoreactive T cell. This is a normal mechanism. Whenever you have a loss of immune tolerance, then there is lots of immune cells which are autoreactive. They start developing. So this leads to the dysregulated immune system. Then dysregulated immune system, they involve and activate either cell-mediated immunity or humoral. Humoral matlab antibody, cell-mediated immunity means cell-mediated immunity. So finally, they leads to a different mechanism, inflammation, and finally destruction. So, what is a mechanism to treat this rheumatological disease? One, first, our priority is to stop the destruction. So, any drug which helps in the inflammation along with immunosuppression like steroid, this is our first phase. Then, anti-inflammatory drug. Obviously, some drug which having some immunosuppression along with some antidepressant, they are here. Then above goes. So answer is that first you have to prevent the inflammation, that is steroid, then along with immunosuppression. Then subsequent plan is patient can maintain here. So this is a mechanism, immunological mechanism of any rheumatological disease. Loss of tolerance, autoactivity, autoimmunoactivity, then inflammation, then damage. Next slide, please. So for the autoimmunity, first thing, because you want to engage a T cell, that is autoreactive T cell, means that T cell which is capable to recognize the endogenous or harmless antigen. So how this antigen present? This antigen present through the antigen presentation. So any innate cell through the innate receptor, they recognize some antigen, they engulf it and present it to the MHC molecule. So first thing is that through the innate receptor, with the help of MHC, they present to the T cell, then T cell become activated. So this is the first process, that antigen presentation. So antigen presentation needs the phagocytosis, then the lysosome. pH is very important. Lysosome has an acidic pH, which can chop the antigen in the appropriate manner. Next slide. So, same thing in a different manner. First, antigen recognition and presentation. This is called signal one. So, antigen is recognized, that is foreign. Through the innate immunity, they present it to the MHC, then the T cell. Then second part is co-stimulation, then co-stimulation to that cell. The T cell got the activation. Then the third part is polarization. Polarization means there are many variety of the T helper cells. They can be T helper 1, T helper 17, T helper 2, T regulator. So on the basis of the different cytokines, suppose environment has IL-12. So the T cell will go towards the Th1 and this pathway is important in RA. Suppose the surrounding cytokine is IL-6 and IL-23. Then the polarized cell will be Th17. Then the principal cytokine will be TL17. This is a principal disease of spondyloarthritis or psoriasis. Suppose the polarizing of signal 3 is IL2, IL4. Then the TH2 form that leads to the atopy, EGPA, then humoral part of SLE. Then suppose every inflammation has subsided, immune system wants to shut off, then nearby TGF beta will secrete that create a T regulator that controls the immune cell. Then there is another thing in which T helper cell stimulate the B cell and B cell forms the antibody. So these are the different mechanisms. So we can stop the antigen presentation. We can stop the antigen presentation at MHC. We can stop antigen presentation at co-stimulatory molecule through different cytokines and through different drugs which are acting against the antibody. Can you change the slide? For any immune system, they are secreting the cytokines. Cytokines are the protein. Protein is being secreted by the messenger RNA. Messenger RNA has to be created by the DNA, and DNA has to have a subsignal that is known as transcription factor. So we have two important transcription factor: nuclear factor kappa beta and nuclear factor activation of a T cell, NFAT and nuclear factor kappa beta. So nuclear factor kappa beta is more concerned with the innate cells antigen presentation and mechanism involved with antigen presentation. And fat is involved with more T cell. So whenever any cell which is stimulated through the innate immunity or antigen presenting cell like macrophage, dendritic cells, they stimulate the nuclear factor kappa beta. Nuclear factor kappa beta goes inside the nucleus and they start creating the different cytokines like TNF alpha, IL-1, IL-6, co-stimulatory molecules, then enzymes. Similarly, N-fat is involved in the stimulation of a T cell. So nuclear factor kappa beta is important, nuclear factor T cell is important. Next slide. So this is our T cell. First time this autoreactive T cell, this T cell can recognize the antigen presented by the MHC. Unfortunately, this was the self antigen. So MHC T cell, along with the help of co-stimulation, finally T cell becomes first start. That start with the CD3. CD3 increases the intracellular calcium, which somehow increases the calcineurin enzyme which activate the nuclear factor kappa beta in a dephosphorylated state nuclear factor kappa beta. NFAT. So these dephosphorylated NFAT can goes inside the cell. They can secrete the IL-2. IL-2 can work in IL-2 receptor. Through the JAK, they involve mTOR, means cell cycle. So signal 1, 2, 3, some growth factor, some cell cycle. These are the T cell stimulation. Next slide, please. So we can block the first part, CD3. This is known as muronimab. We can block the directly T cell receptor through anti-thymocyte globulin. We can block the co-stimulation to belatacept, abatacept. We can block the calcineurin. That is a T cell stimulator through cyclophilin. Through cyclophilin, we have cyclosporin. Through different part, we have tacrolimus, pimecrolimus. Different molecules are there which can inhibit the T cells. So these are the broader classification. CD3 inhibition, co-stimulation inhibition, T cell inhibition, mTOR, then antimetabolite. Next slide. Then through a different cytokines, because after all these cytokines secrete, so we can block the different cytokines. That's why we have TNF inhibitor, IL-1, IL-1223, IL-23, different inhibitors we have. This is not today's topic, but we have different inhibitors in rheumatological diseases. So this is a cytokine inhibitor. Second part. Third, please upgrade it. Next slide. So antibody, whenever you have a pathological antibody that recognize the antigen, then this Fc portion becomes activated. Then Fc portion, they can stimulate the complement and create a death. This is known as complement dependent cytotoxicity. Then antigen bind to the antibody, then Fc portion becomes activated. Then Fc portion got attached to the Fc receptor of the natural killer cells. They got again damaged. So this is known as antibody-dependent cytotoxicity. So we have two kind of cytotoxicity: complement-dependent and antibody-dependent toxicity. That is antibody-mediated. Next slide. So we can inhibit this antibody formation through antibody reaction can be type 2, type 3. Type 2 means localized. Type 3 means generalized, like lupus nephritis and PSLE, where is a immune complex is circulating. Type 2 is a local, like hemolytic anemia, peripheral neuropathy. So for the antibody reduction, we can use IVIG, rituximab, and different other B cell depleters. For immune complex, we can use plasmapheresis. For complement, we can inhibit the complement like eculizumab, C5 inhibitor, like C5a receptor avacopan. Next slide. So these are the different mechanisms to deal with the immune system. So you can understand some drugs which are acting beyond above the cell, not inside the cell. They are large molecule, protein molecule. So this molecule is known as biological molecule. They inhibit either cytokine directly or their receptors. And they are targeted. So infections are less. Some is called small molecule. They work inside the nucleus, inside the cell. They can inhibit the enzymes. They can inhibit the transcription factor. They can inhibit the different pathways of the enzymes. That is called small molecules because they are working inside. So among the small molecules, we have TS-DMARDs, targeted synthetic DMARDs, which can inhibit the JAK inhibitor on phosphodiesterase 4 inhibitor or conventional synthetic DMARDs which are inhibiting the cell cycle and other things. So they are non-selective inhibitors. So theoretically, they have more infections. So this is part one. Next slide. So small molecule can be divided on the basis of the two parts. One is a non-selective, purely non-selective, that is known as CSD-MARS. Among that, we have methotrexate, hydroxychloroquine, azathioprine, leflunomide. Previously, we are using gold and all the other things. These are known as CSD-MARS. Then targeted synthetic DMARDs. They are inhibiting the certain enzymes like JAK inhibitor and phosphodiesterase 4 inhibitor. So they are relatively fast acting and side effect wise also come theoretically less, but we can't say practically. Next slide. So now we are discussing with the first DMARDs, that is a methotrexate. Methotrexate in 1940s, what they found, initially what they found anemia. Scientists want to treat the anemia. They found there is a megaloblastic anemia. Despite of giving B12, patient was not improving. So they start giving folitrax, folic acid, vitamin B9. The patient start improving. So that was the inception part of a folic acid. So folic acid was initially incepted. They are thinking that is improving anemia and megaloblastic picture. But what happens in 1940s, patient of the acute leukemia, especially child, they used to come with the acute leukemia and megaloblastic anemia. They tried to treat with the folic acid, but disease deteriorated. Then they tried the antifolate and disease improved. So point is that in 1930s, 40s, folic acid was discovered. This folic acid was known to as a proliferative agent. Then for the cancer, it used as an anti-proliferative agent. This was the discovery of a methotrexate around 1930s to 40. Next slide. This person's name is Dr. Yadla Parado Subbarao. He was Indian. He took the participation in the Quit India movement. He was a part of freedom struggle. He was doing his MBBS from Madras Medical College. But due to his inclination towards the Indian freedom movement, he was not awarded as MBBS degree. He went to the America and becomes the biochemist. He is a person who discovered folic acid, who discovered methotrexate, who discovered ATP as a source of muscle contraction and cell energy. And he also discovered tetracycline, doxycycline. So why I put his name? Because he was because methotrexate is a pioneer drug in rheumatology. and that was discovered by the Dr. Yella Prado Subbarao. And I want every rheumatologist and rheumatologist parent to know about him. Next slide. In the left side, we are seeing the structure of a folic acid. In folic acid, we have pteridine ring and then glutamic acid. Then some structure here is a pteroic acid. So if you see the methotrexate, so methotrexate has extra methyl group instead of the amino group, and extra amino group here. So because of the amino group and metho group, this is called as amethopterin. So amethopterin was a methotrexate, which was a analog of folic acid. Next slide. What is a normal rule of folic acid? Folic acid, once goes inside the body, they convert into tetrahydrofolate with the help of enzyme dihydrofolate. Then this tetrahydrofolate is important in the purine synthesis and pyrimidine synthesis, which is a building block of DNA and RNA. That's why they created DNA, RNA, helps the dividing cell like bone marrow cell, GIT cell, liver cell. Okay. Then folic acid uh, convert to the tetrahydrofolate, and tetrahydrofolate convert homocysteine to methionine. So they decreases the level of homocysteine also. So two things are there. They are helping in DNA synthesis through purine and pyrimidine synthesis, and they are decreasing the homocysteine. Homocysteine is associated with atherosclerosis, and DNA is important for the life. Okay, next slide. So methotrexate, as I told, it's a folic acid analog. It behaves like a folic acid, but it got access to the cell through a receptor which is called reduced folate carrier. Reduced folate carrier means a folic acid with a hydrogen. That is called reduced folic acid. And folic acid has access through folate receptor. So folic acid goes inside and they create DNA and RNA and homocysteine level, all other things. But methotrexate goes inside, then methotrexate convert into the methotrexate polyglutamate, which is a cellular trapping of a methotrexate. Once the methotrexate is trapped intracellularly, they can inhibit the dihydrofolate reductase, means anti-proliferative action, anti-DNA action. Thymidine synthetase means they are inhibiting the pyrimidine, again anti-proliferative action. These two actions are helpful in cancer to kill the dividing cell. So because of this, dividing part is bone marrow. So you can get bone marrow toxicity, you can get stomatitis, mucosal inflammation, liver toxicity. This is a part of a methotrexate. Second slide. Next slide. So methotrexate got access inside the cell through reduced folate carrier that converted to the polyglutamate.
Open this now, sir.
Polyglutamate working on the ICAR enzyme, and ICAR enzyme increase the extracellular adenosine level. This is a role of methotrexate in rheumatology. So intracellular extracellular adenosine level, they inhibit the nuclear factor kappa beta, so they inhibit the inflammatory molecules, inflammatory cytokines, neutrophilic infiltration. So this is a mechanism in rheumatoid arthritis, but adenosine level has some side effect also. That is CNS side effect, like trigeminal system. They got dilated and they behave like a migraine thing, like fatigue, nausea, vomiting. That is due to adenosine. That is due to ICAR inhibition. Next slide. This extracellular adenosine principal action is through adenosine 2A receptor. So they got anti-inflammatory action. But as you know, adenosine also used in PSVT, so they reduces the heart rate also. Adenosine, if they work through adenosine 2 receptor B, they can increase the cytokine, then can lead to the hypersensitivity reaction and muscle degradation. So, methotrexate has two kind of toxicity. One is dose dependent, one is adenosine dependent. Next slide, please. This is only for the PG purpose or need assess purpose. Methotrexate also do the decoupling of the nitric oxide. So nitric oxide decreases. If nitric oxide converted into the oxide molecule, that can lead to the endothelial injury. That is only for MCQ purposes. Next slide. So pharmacokinetics. Absorption. Methotrexate can be taken orally. Up to 15 mg, methotrexate absorption is very good because methotrexate absorption occurs through protein. To protein, there is a limited number of a protein. Beyond 15 mg, you will get a saturable kinetics, means only 70% absorption because all the protein got saturated. So if you want to increase the bioavailability to the oral route, you have to give a splitting dose beyond 15 mg or subcutaneous dose. That is one. That is absorption. So absorption wise, methotrexate can be taken with meal or without meal, except milk. Why milk? Because methotrexate patient can got nausea, vomiting. Sometimes they want to take milk, but milk has a folic acid that can hamper with efficacy. So milk. So point is that methotrexate doesn't affect meal. Second point, up to 15 mg methotrexate single dose is sufficient. Beyond 15 mg, splitting is important, but that splitting should be done within 12 hours. Why saturation is decreases bioavailability? Because after the 15 mg bioavailability decreases because of the saturation of a protein. Second is the distribution. Ethotrexate is principally 50% bind by the albumin. So any disease in which albumin is low, methotrexate toxicity is increases. Or any disease, any drugs which can bind to the albumin that can displace the methotrexate and can increases the toxicity. Third thing, within 6 hours, methotrexate level in serum cycle should become safe. Fourth, how the methotrexate comes inside the cell because methotrexate usually prescribed once a week, with long acting. So why methotrexate, although half-life 6 hours is serum, so why methotrexate is long acting? Because it enters in the cell to produce folic carrier, which is not a case of folic acid. They converted to the polyglutamate form. Here, intracellular trapping polyglutamate form. Once methotrexate converted to the methotrexate polyglutamate, this becomes highly polar, and polar substance can't cross the cell membrane without any help. So they trapped inside. So they inhibit the dihydrofolate reductase. So they inhibit the folate. So they inhibit the DNA synthesis. That is known as anti-proliferative action, principally acting on the anti-cancer drug that is in high dose. In low dose, this inhibit the ATIC enzyme. ATIC enzyme increases the adenosine level, which is anti-inflammatory. So we can say in low dose methotrexate, it can work as an anti-inflammatory more than anti-proliferative. In toxic level, it works more as anti-proliferative. Third thing, metabolism. As other drugs, methotrexate also metabolizes in the liver in a 7-hydroxymethotrexate level. So toxicity wise, we have to be very aware of a liver toxicity. Elimination. Methotrexate is eliminated by the kidney through GFR, glomerular filtration rate, through tubular secretion. So if any part, if any chance kidney failure is there, then we can get more methotrexate. More methotrexate can trap inside the cell, and that can be more antiforeign reaction and more toxicity. Drug interaction. So any drug which is binding to the NSAIDs, albumin, they can displace the methotrexate, increase the toxicity of a methotrexate. So albumin is the acidic drug, acidic protein, acidic the acid drug, like NSAID, non-steroidal anti-inflammatory drug. So they increase the methotrexate toxicity. Then trimethoprim sulfamethoxazole. This is the anti-folate drug. So double anti-folate drug can cause toxicity of methotrexate. Penicillin and PPIs, they hampered the tubular secretion of methotrexate. So point is this oral up to 15 mg oral is okay. Beyond 15 mg patient is accepting the subcutaneous dose is okay. Otherwise, splitting dose. Why methotrexate is acting longer? Because it is acting in the and supplement to prevent the anti-folate action. We have the folic acid 5 mg, then 5 mg. Uh, some patients, some doctors giving 1 mg to 3 mg once time or two times. But I'm telling कि transportation inside the cell of folic acid is not through reduced folate carrier. To methotrexate, whether you give folic acid or without folic acid, it will go inside. But folic acid will prevent the inhibition of the dihydrofolate reductase. So it can inhibit the anti-proliferative side effects. So folic acid giving 6 days in a week, even 7 days, is not a bad option. Next slide. So methotrexate 30% protein count half-life is here. It can accumulate in the third phase like pleural effusion hepatitis. Any patient have pleural effusion hepatitis, which is common in RA also, like pleural effusion. That can lead to the toxicity. If patient has any problem, I told you tubular filtration and tubular secretion. Then little bit distal tubular absorption is there. So means secretions, then one absorption. And how methotrexate is working long acting despite 6 hours in a serum because methotrexate inside the cell work as a methotrexate polyglutamate form, which is a polar form. That's why it trapped inside the cell. Next slide. So this is again comparing the subcutaneous. So in this chart, I just want to come to you. Suppose we are giving methotrexate 20 mg or 25 mg to a patient, even in a static dose, the response is not coming. So we can try subcutaneous. Because subcutaneous variability is 100%. The first thing to increase the efficacy, you can try the subcutaneous beyond 15 mg. You can try the subcutaneous part. Subcutaneous bypasses the GIT. So there is two kind of nausea in the case of methotrexate. One adenosine mediated, that is immediately after taking methotrexate. Another is kind of GIT through that is after 24 hours. So suppose you are having a nausea vomiting which is due to the anti-cancer kind of side effect. So you can use subcutaneous dose of methotrexate. So subcutaneous is better for increase efficacy, increase the bioavailability, to reduce the side effect. Next slide. Next slide. Next slide. So, methotrexate in combination. So, you can understand methotrexate we are using here. So, methotrexate is a drug which can use in a triple therapy like methotrexate, hydroxychloroquine, in RA. We can use methotrexate plus flavonoid. We can use methotrexate plus mycophenolate mofetil. We can use methotrexate with biologics. We can use methotrexate JAK inhibitors. So, methotrexate is a anchor drug, go and go drug. आ जाने ही चाहिए methotrexate. So this slide is for कि don't fear while mixing methotrexate or giving methotrexate along with the JAK inhibitor or biologicals. Second, next slide. Now, mechanism of a side effect of a methotrexate. I told you, methotrexate side effect one is through diet reductase. That is an anti-proliferative. Which organ will be involved in a proliferation, which is more proliferative, like bone marrow. So bone marrow is continuously dividing, that's why bone marrow suppression. Stomatitis. Mucosal continuously dividing, that's why stomatitis. Hair, then alopecia. This is called antifolate. So what is the treatment of antifolate? Give folic replacement. Two forms, either folic acid or directly folinic acid prescribed. Second, methotrexate is working principally in the rheumatological disease through adenosine. So adenosine can cause nausea, vomiting, headache. Adenosine causes the vasodilation. So we can inhibit the adenosine through caffeine mechanism here. Third, I told you methotrexate is working through adenosine. Adenosine works through the different receptors. Among that, one of the receptors is adenosine 2A receptor, which increases the mast cell activation. That can cause methotrexate pneumonitis. Then here, methotrexate is clearing through the kidney. If there is any problem in the kidney, then methotrexate can cause pneumonitis. And methotrexate is metabolized in the liver and patient has multifactorial disorder because psoriasis itself is fatty liver, alcohol, multiple painkillers. So methotrexate can cause toxicity, liver toxicity. Next slide, please. Treatments. Suppose patient to methotrexate more than what is required, or in a daily basis. So what is happening? Patient is inhibiting the hydrofolate reductase. So patient is inhibiting DNA. Any cell which is dividing fast, that cell will involve first. So, methotrexate toxicity leads to the bone marrow suppression. Bone marrow suppression leads to the anemia, thrombocytopenia, etc. things. So, how to rescue the disease? Because methotrexate is going inside the cell through reduced folate carrier. So you can give directly reduced folic acid, that is folinic acid, in every 6 hours. Second, despite of giving all these medications, because this will help in the cell. Suppose methotrexate already gone inside and start acting. So we can create the we can stimulate the bone marrow through GCSF, granulocyte colony stimulating factor, that is known as filgastrin. Dose is 5 microgram per kg, approximately 300 once a day. In 4 5 days, big patient becomes okay. We are giving Trexate 2 years, 3 years, 1 gram, 2 gram. Patient is psoriatic arthritis or alcohol or something, metabolism level, the patient can lead to the hepatic toxicity. So here you need to address the patient that no alcohol use, no hepatotoxic drug use. Here, no daily use, regular folic acid use. If there is a toxicity, folic acid rescue, him. Then another side effect which is at low dose for adenosine level. Because of the adenosine, patient is having nausea, vomiting, headache. So you can give NADA antagonist or dextromethorphan 30 to 60 mg or vitamin A, 1 lakh unit for 1 week before giving the drug. Even tea or caffeine, which is the same receptor, which can also be helps to mitigate and resist toxicity. Second slide, another slide. This is individual go by go, like GI side effect. So GI side effect can be two types. Through anti-cancer drug means after taking methotrexate after 24 hours or she's having nausea, vomiting, everything. That is okay. That is the GI irritation. Another thing, patient is taking methotrexate immediately having all the side effect that is due to adenosine. So if delayed toxicity is there, folic acid will help. Or if adenosine toxicity, then caffeine or vitamin A or dextromethorphan will help. Alcohol. Alcohol is a non-nutritious nutrition. Means alcohol is a food, but without nutrition. You need to have a folic acid to utilize the alcohol. So alcohol, once two things are there. Alcohol is a hepatotoxic. Alcohol is also using your folic acid. So alcohol definitely no. Hepatotoxic no. So this is healthy liver fibrosis. So and some data is here which is in Hogberg. Methotrexate alone study किया गया था. Where do you have a 22% AST ALT elevation more than the upper limit. 32% along with the leflunomide. Means methotrexate plus leflunomide you can give, but the chances of more liver toxicity. And more than 2% is 1 to 2%. What is recommendation? If it is more than 3%, you can use methotrexate. But despite persistent increase, even by one times, is also an indication to stop the methotrexate level. Okay, next slide. Methotrexate is itself as an abortive agent for the ectopic pregnancy. Methotrexate is a drug of choice because methotrexate is hampering the DNA synthesis, and newborn baby needs the DNA. So methotrexate should not give nothing for any consumption. That is one. Second, methotrexate is trapped inside the cell in the methotrexate, which is very important. So if anybody is planning for the pregnancy, then patient should be off without methotrexate since last 3 months. And most of the rheumatological patients are reproductive age group female. That's why while prescribing methotrexate, you have to be very clear कि you can't be you should plan pregnancy with your doctors also after your discussion with your doctor because methotrexate is about efficient. Next slide. So pregnancy, I told, it's contraindicated in pregnancy. It's teratogenic and effective contraception is important. Methotrexate, as a patient becomes old, his or her kidney becomes also weak. As we know, 80% of our methotrexate is cleared by the kidney. So on old age, chances of methotrexate toxicity is high. So starting dose of methotrexate in old age is a 7 mg maximum 20 mg. That is there. Pediatrics. They can tolerate methotrexate very better. So up to 25 mg to 30 mg we can give in the pediatric population. This is for the special population. Pregnancy, absolutely no. Old age, reduced dose. Pediatrics, no worry if indication is proper. Next slide. Drug interaction, I told, methotrexate is a hepatotoxic drug. So those drug which is a hepatotoxic like other DMARDs like leflunomide, sulfasalazine combination can leads to more hepatotoxicity. And sulfasalazine also got access to the cell through default carrier, so it can reduce the efficacy of methotrexate also. But this is a theory. This is one. Second, any drug which can displace the methotrexate from the albumin can increase its toxicity. It lets cell promotes it inhibits its tubular secretion. I told you, body doesn't want methotrexate in serum. 100% glomerular filtration, total filtration they want tubular secretion. Okay. But along with hydroxychloroquine increases the methotrexate level. Third thing, because patient are old age or giving the combination therapy, lot of side interactions are there, but we are using methotrexate at low level. So these drug interactions are not very common in RA. So we can give all these drugs together. But one thing is important, uh, uh, competitive trioxazole can lead to the bone suppression. That need to be remembered because in giant cell in unconstipated vasculitis, cotrimoxazole is also indicated. Next slide. Methotrexate in heart disease. This is important because rheumatology itself can increases the inflammation. Chronic inflammation and sporadic inflammation can lead to the heart problem. So methotrexate to decrease inflammation through anti-inflammatory effect, it can help in the heart health. But methotrexate while increasing because it increases the folic acid, which is a helpful for which is a molecule which converts hormones into methionine. It increases the homocysteine levels, so heart problems can increase. Overall, lots of studies are done. They told methotrexate is helpful in reducing heart disease because of its anti-inflammatory effect. Next slide. Now leflunomide. Hello, my voice is coming.
Doctor, now we can hear you, but there's a lot of disturbance.
Okay, 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 okay. Okay. Can we go ahead with leflunomide?
Yes, now it's clear.
Hello? Yes. Okay. Previous slide. Then leflunomide. Leflunomide is another immunosuppressive medications which inhibit the pyridine through dihydroorate dehydrogenase enzyme. So it inhibits the dihydroorate dehydrogenase enzyme, which inhibit the further pyrimidine synthesis, which leads to DNA blockage and leads to the nuclear factor kappa beta inhibition. So this is also a immunosuppressive medication. Next slide. It is bioavailability wise, it is absorbed very easily absorbed, metabolized in the liver. So hepatotoxicity is a problem. It's 99 bind to the 99% bind to the hemoglobin. Volume of distillation is high, but problem is that it goes into the enterohepatic circulation. Means it will run between intestine and liver again and again and again and again for the years. So and this is a teratogenic drug also. So any patient who is on the leflunomide, we need to do the washout before doing the before planning for the conception. Next slide. So here I told you leflunomide along with sulfasalazine methotrexate, it can cause hepatotoxicity. Uses are in the psoriatic arthritis, rheumatoid arthritis, LN, different diseases are here. Oh, and nowadays, lutein is not given. We are giving up to 10 mg or 20 mg. Next slide. Toxicity wise, as I told you, this can cause the liver toxicity, lupus pneumonitis, hepatic toxicity, and some blood dyskinesias also. Next. GIT toxicity is one of the reason to discontinuation of a drug. Next slide. Hmm. Next slide. Hydroxychloroquine. Okay. Hydroxychloroquine, actually in 1600, this drug was made for the malaria and they developed from the cinchona bark. So in Second World War, history-wise, that in Second World War, what they gave chloroquine to the troops who are going to the malaria endemic area. What they found after giving chloroquine, that incidence of the joint pain and skin rashes in autoimmune diseases decreases. So in this way, they found that this has some immunomodulatory action. So this was the discovery of the hydroxychloroquine. Next slide. Hydroxychloroquine is a basic drug, so it can easily cross the membrane. And I told you the lysosome. Inside the lysosome, it is an acidic lysosome which chop the antigen and create the antigen presentation. But because cell membrane is lipophilic, hydroxychloroquine goes inside the cell and disturb the pH of lysosome and created this basic. So it hampered the antigen presentation and TLR9 and TLR7 presentation. Next slide. Because hydroxychloroquine is a basic drug, so it can bind to the basic structure. So it binds to the retinopigmented epithelium. It can cause the macular toxicity in skin. It can cause the hyperpigmentation. So retinopathy and skin involvement. Why? Because it's a basic drug. Because of basic nature, it reduces the MHC. It reduces the T cell activation. Next slide. Because it reduces the antigen presentation, so definitely it is using in any seropositive disease. Seropositive disease means connective tissue disorder. So it is useful in SLE, cutaneous SLE, hypocomplementemic arterial vasculitis, Jordan antiphospholipid syndrome, sarcoidosis, different diseases. Next. Because of a basic nature, it deposited in eye, it can cause the bullseye maculopathy. Because of its basic nature, it can hamper the lysosome of muscles, can lead to the muscle problem. It can lead to the heart block, GIT problem. Because of the basic nature, it can deposit to the melanin of a skin and cause the full skin problem also. And it increases the insulin half-life, so it can cause the hypoglycemia or helpful in diabetes. Next. So this is useful in all seropositive diseases like SLE, RA, Jogan. Antibodies are positive. Palindromic rheumatism, JIA, discoid, and different. Important thing is that it is not useful in seronegative things like psoriatic arthritis, ANCA vasculitis, although seropositivity is there, but it is not useful. Takayasu arthritis, giant cell arthritis, polyarthritis nodosa, and especially in scleroderma. I just want you to remember HCQ is not useful in scleroderma. Next slide. Sulfasalazine. Next. Initially in 1930s, Dr. Nana Swartz, he thought rheumatoid arthritis is because of some infection and joint pain. So his hypothesis was it was an infectious disease. So he combined the antibiotic sulfaparidine along with 500 salicylic acid, means one painkiller, one antibiotic, and it works. But 40 years later, Sidney Trullo, he understood that this drug is working through the immunomodulation. So sulfasalazine works through the immunomodulation, although it's a combination of antibiotic and NSAIDs. Next slide. Sulfasalazine is a combination of a sulfapyridine. Previous slide. sulfapyridine and aminosalicylic acid, they both are bound to the azo bond. That is a very strong bond. So in large intestine, we have a bacteria, colonic bacteria, which can break this azo bond. So they separate it into the 5-salicylic acid and sulfapyridine. In the colon, pH is basic. Sulfapyridine is like, so it absorbs. And 5-aminosalicylic acid is a acid in basic media tract. So it works locally in the colon and this works inside the cell. But what we found in rheumatoid arthritis, sulfasalazine itself, not individual sulfapyridine or 5-aminosalicylic acid, they work as a immunomodulation through inhibition of a nuclear factor kappa beta. That's why low IL-1, IL-6, TNF-alpha. So this is a mechanism of sulfasalazine. Next slide. Toxicity because of a drug, GIT toxicity is there. Dermatological, this is very important. This is a sulfur drug. It can cause a rash, urticaria, photosensitivity, Steven-Johnson syndrome. Because of a sulfur drug, you can get the orange skin, orange urine also. Hypersensitivity reaction. Hematological, it's a sulfur drug. A patient has G6 protein deficiency that can lead to the autoimmune hemolytic anemia and different things are there. Next slide. So sulfasalazine is useful in rheumatoid arthritis, not in axial spondyloarthritis. It is useful in peripheral spondyloarthritis. This is very important. Many physician is still giving the axial part. That's not good. For inflammatory bowel disease, reactive arthritis, and GIA. Next slide. So summary. Hmm. Methotrexate, we have to do the routine CBC, LFT, RFT, viral marker, and all these things in every month, 3 months, then 3 monthly. Leflunomide, same every month, 3 monthly. Then hydroxychloroquine at baseline, eye examination, and after 5 years, eye examination. Next slide. Here, methotrexate principal action in rheumatology, ICAR inhibition, that is adenosine. In cancer, dihydrofolate reductase, that is pyrimidine synthesis, that is an anti-cancer drug. Leflunomide, this is a pyrimidine synthesis inhibitor through dihydrourate dehydrogenase inhibitor. Sulfasalazine through nuclear factor kappa beta. Hydroxychloroquine, integer precipitation, and TLR. Next. These are the questions. Suppose patient have a methotrexate toxicity. What is your drug of choice? That is leucovorin. Reversible oligospermia, sulfasalazine. To all these questions and liver toxicity, sulfasalazine, methotrexate. So in this way, just I want to conclude all this slide. I know this was a very big and boring slide, but this was important. Last slide. Next slide. Thank you all. Hello.
Uh, Thank you, Dr. Tiwari.
I think I think some communication problem was there.
Yes, there was few disturbance, but still the session, I must say, it was a very, insightful and very informative session. And that too, you have tried to comprise all the things in a very, concise manner. You have tried to cover
Yeah.
major drugs. So that was, sir, very nice. And we sincerely appreciate your efforts and sharing your valuable expertise with us. So now we'll just check if some questions are there. So let me just check, sir. Uh, so there's a question in your clinical practice, how do you decide the choice of first line conventional DMARDs in newly diagnosed RA patients?
No doubt, right, left, center, anywhere, until unless there is a not no contraindication, methotrexate will be the first line. Reasons are there. Since 1988, means from 1990, you can say, since last 36 years, we have a big data. So we can say it's a safe drug. First, that is the first thing. Second, we have seen the efficacy also. That is second. Third, we can combine it with other drugs also. So first thing I want to convey, please don't fear about the methotrexate. Methotrexate is a go-to drug with RA.
Thank you, sir. And another question which I could find, sir, how do you manage a patient who becomes pregnant on methotrexate?
That's a good question. Actually, while my presentation, also because of lots of interruption, I was unable to tell that hydroxychloroquine and sulfasalazine, these two drugs are safe in pregnancy. So whenever patient got pregnant, we try these two medications. Second thing, in rheumatoid arthritis, one third, by God grace, one third of a pregnant female, they got remission while the pregnancy. One third got the same disease activity previously, the patient becomes pregnant. One third disease can be activated. So it depends upon the patient situation. Sometimes patient by themselves becomes in remission. And definitely no use of methotrexate, no use of azithromycin, no mycophenolate mofetil. These three things, or methotrexate, you have to remember.
Thank you so much, sir. And maybe some other questions are there, then we'll just connect with you for the same. So I think that's okay for now. And it was a very nice session with you, sir. And we all are eagerly waiting for your next series of your academic session. So I thank all the participants for being a part of this insightful session. And we'll be soon coming up with the next session and carrying forward this academic series. So that's all from now, sir. Thank you, Doctor.
Thank you so much for the whole Concard team, and thank you so much for the whole in every participant who participated in this program. I know some technical glitch was there, but next time we will try to fix it all. And I am sincerely want to teach all the patients in my whole capacity. So please be with us, and please be in joining in the second and fourth Saturday. And till now, enjoy studying and keep reading.
Yeah. Thank you so much, sir. Thank you, all the participants. Good day, good night.